welcome to our program tonight, Advancing Personalized Care in Renal Cell Carcinoma. There are so many different choices for where you could go this evening, and frankly, I think you chose the best venue. I mean, I'm a little biased. I didn't recognize the folks in that other RCC program, so I think this is definitely the place to be. But no, we really do have a terrific panel tonight. We're going to have a lot of exciting discussions. I'm going to introduce everybody one by one in just a moment here. I encourage you all to visit us at peerview.com and go to the link RCCSF24. You can view the slides, all the practice aids. You can download them after the event. Everything that we're going to be putting up on the screen is going to be readily available to you. And we have a number of different goals for today. We want to augment your knowledge of the latest efficacy and safety data for approved therapies for RCC. We're going to talk about personalizing care, and I usually like to do this in the form of zingers, which are really tough clinical scenarios that I don't have answers to, but I expect answers from the panelists. And then we'll provide you with approaches that we're using in the clinic to manage our patients with kidney cancer from day to day. I want to extend a heartfelt thanks to Dina Battle and Casey Cure. Casey Cure's research mission is exactly in line with what all the investigators here tonight are really trying to do. We want to provide answers to questions that patients and caregivers are asking. Casey Cure does these tremendous polls, and I've had the pleasure of working with them on several, which really address key pertinent questions around evolving therapies for renal cell. And we'll actually highlight some of the data that Dina and her colleagues have assembled tonight. And many of you, of course, are here in the room, but many more are actually joining us virtually on an iPad. And so please take a moment to answer these survey questions that you see in blue on your iPads as they pop up, if you don't mind. And with that, I'm going to turn it over to Dr. Tian Zhang, who's an associate professor at UT Southwestern, a dear friend and colleague who's done a lot in the field of renal cell, and she'll be discussing the latest evidence for perioperative strategies for local, regional, or resectable renal cell. Tian?
Thanks so much, Monty. Great to see everyone out tonight. Thanks for coming. So we'll talk about perioperative strategies for resectable renal cell carcinoma. I don't think my clicker is working. There we go. Okay. So we know that in patients who have their kidney cancers resected, there are some limited options. And as even 2 years ago, we had very limited options and different benefit from sunitinib. But about 2 years ago, we've really opened up our options with immunotherapy. So we'll talk about the perioperative systemic treatment options in the adjuvant setting. We'll talk through the data there. And I do think we do need to reduce recurrence. If that's a surrogate, if disease-free survival is a surrogate for overall survival, then reducing recurrence is a really important factor in patients who are post-surgery. And there's a need for effective therapies and moving what we know in advanced disease and metastatic disease earlier in the disease course. It's really important to think about effective strategies in earlier disease states. So here we go. I am still
Try this one, Tian. I think this one's working.
Thank you, Monty.
Yeah.
All right, so there's a variety of approaches for calculating recurrence risk in my clinic. If you're a fellow rotating with me, we always sit down and think about patients when they're making this adjuvant decision. We think about their baseline recurrence risk. So there's a couple of calculators that are online. The QR codes will lead you right there. The Assure nomogram is on the left side, and the UCLA nomogram is on the right side. But these are features of the patient at clinical and pathologic features of their tumor at the time of their resection. And when you put in all of their characteristics, the pop-up is a disease-free survival curve. And what we usually read out is a 2-year disease-free survival rate. And then we have that as sort of, if you did not go on treatment, this would be your 2-year disease-free survival rate and the risk of recurrence. And then, if we did your adjuvant treatment, this is what your potential benefit might be. So we have this conversation a lot in my clinic. What do patients perceive when they're thinking about the benefits and risks of adjuvant treatment as they're post-surgery? So this is data actually from Dina Battle and the Casey Cure surveys that Monty talked about earlier. But this is more than 1,000 participants, and talk about numbers in surveys. But these were patients with a median of 57 years old who self-identified with localized renal cell carcinoma and a good 20% of them had stage 3 disease at the initial diagnosis. And so if you're looking across those bar graphs below, you're seeing both the physician assessment of their risk as well as the patient assessment of their risk. And so if you look, the blue bars are always a little bit more than the purple bars. And so this tells us that the patient's anxiety and thoughts about and what they perceive as a risk of recurrence is always a little bit higher than what the physician thinks. And from potentially the recurrence risk calculators and what we know in clinical practice, the patients often will perceive their risk of recurrence higher than their physicians. All right, so when we talk about adjuvant treatment decision making, I'm always talking about balancing that benefit versus risk. So we have the potential benefit of preventing disease recurrence and hopefully getting patients to live longer, but ultimately anybody receiving adjuvant treatment is receiving treatment in a disease-free state when they're not having symptoms necessarily of any kidney cancer, but if they're having side effects from their treatment, then potential toxicity and their side effects and symptoms from the treatment toxicity. And so then, and potentially their inconvenience and cost of treatment are all factors that we take into effect when we're thinking about the adjuvant decision-making process. So these are multiple small molecule inhibitors that have been tested in the adjuvant space. The only trial that was positive was STRAC with sunitinib, which we won't talk too much about, but the disease-free survival endpoint was met, but overall survival was not. And this sunitinib was FDA approved not too long ago, 2017, within our careers. And the uptake of the use of sunitinib in the adjuvant setting really wasn't quite as high as what we'll see with immunotherapy. So there have been 4 adjuvant trials reported so far. I'll walk you through some of these in each of these slides. PROSPER RCC was a cooperative group trial run in the ECOG and across the NCTN cooperative groups. This is a trial of perioperative nivolumab, a dose before surgery followed by nivolumab for 9 doses versus surgery alone. And you'll see the data safety monitoring committees actually stopped the trial at the interim analysis, where the median follow-up was about 16 months, and there was no difference in their recurrence-free survival between the cohorts. And I am told that this data is coming to a manuscript sometime very soon. All right, so Emotion 010 was a second trial that had a negative result. This was a trial of atezolizumab versus placebo in the adjuvant setting for high-risk localized renal cell carcinoma. Median follow-up here was almost 4 years, and the median disease-free survival was about 57 months versus 49 months in the patients who were treated with placebo. And so no difference in disease-free survival, and the median overall survival was not reached. And you see these curves lie right on top of each other, showing no benefit of atezolizumab. And then finally, the final negative study we'll talk about is Checkmate 914, which was 6 months of nivolumab and ipilimumab in this particular cohort compared against placebo. And you see these curves of the combination also lie right on top of the patients treated with placebo. At the median follow-up, just over 3 years, the disease-free survival was not reached versus 50.7 months, and again, not statistically significant. We're about to see the 3rd cohort of Checkmate 914 report out on Saturday. So the nivolumab versus placebo cohort. This is a late-breaking abstract, and so we'll see that the abstract in the morning, and then the oral presentation shortly thereafter. So stay tuned on Saturday. All right, and then finally, we'll talk about adjuvant pembrolizumab. So Keynote 564 was a positive trial in the adjuvant setting of clear cell kidney cancer, stratified based on the presence of metastatic disease that's been surgically resected, and also on performance status and within the US versus outside the US. But patients were randomized to pembrolizumab versus placebo, and disease-free survival was the primary endpoint, and they were able to also save some power to then look at overall survival as a key secondary endpoint. So the primary endpoint of disease-free survival was met at the first analysis at 2 years, and then we subsequently had a 30-month follow-up, and you see the two disease-free survival curves. We've seen this multiple times now with an improvement in disease-free survival for patients, particularly at that 2-year landmark rate. 78% of patients treated with pembrolizumab were free of disease. All right, and then disease-free survival by recurrence risk groups are intermediate risk and high risk versus high risk in M1 NED populations. You do see the absolute benefit of patients treated with pembrolizumab increasing as we go into the high risk and M1 NED patient populations. And so we do think there's some difference in patients who are intermediate high versus high and also M1 NED. All right, key secondary endpoint of overall survival. These data were presented with the primary and the updated analyses at 24 and 30 months respectively. You see the hazard ratios are right around 0.5, 0.52 at the most recent update. There was a press release earlier this year that the overall survival had met all the events needed and was a positive study. And so we will also see that. It's another late-breaking abstract, again, also on Saturday morning. 8 a.m., be there, and we will see the data together. All right. Treatment-related adverse events. We talk about this a lot in my clinic as we make this patient-driven treatment decision, but thinking about the side effects that occur with a year of pembrolizumab. So we talk a lot about fatigue and pruritus, the endocrinopathies. If you look, there's a little bit of grade 3 diarrhea and rashes, but ultimately, single-agent pembrolizumab, we can get most people through the side effects and toxicities. And the spectrum of immune-mediated adverse events are quite significant. They can affect most organ systems. And I won't belabor this point, but we do have to think about the potential for adverse events, immune-mediated, and also for severe immune-mediated adverse events as they occur at any point through the course of immunotherapy treatments. And Dr. McDermott will be talking more about all of our immune-mediated toxicities and the timing of those when we get into the immunotherapy combinations. There is a adjuvant trial that's actively enrolling. This is LIGHTSPARK-022, which is based on the positive results from Keynote 564. This is all patients with high-risk clear cell kidney cancer randomized to either the combination of belzutifan, a HIF-2 alpha inhibitor, with pembrolizumab versus placebo with pembrolizumab. And again, the primary endpoint around disease-free survival. I want to take us back to the patient perspectives because this is a very much patient-driven decision whether they go through a year of treatment. And this fear of cancer recurrence is a data point also from Dina Battle and Casey Cure, where the rates of distress really decrease over the course of time. But it's a point about the mental burden of potential for recurrence. And so as there are many years and months out from their surgeries, and as they become longer away from the time of surgery, their distress decreases, what you see on the left, but they still have some mental burden as they come for scans over the course of time, and that fear of cancer recurrence continues to linger over the 40 months that these patients were surveyed. All right, so at the end of the day, when we're talking about in our clinic visits and balancing that benefit versus risk disease of adjuvant pembrolizumab and treatments in this adjuvant setting, we're really thinking about the potential benefit of a treatment that potentially grade 3 toxicity is low. There's now improved overall survival and to try to prevent disease recurrence, but also thinking about the toxicities and and the potential severe toxicities that can be life-threatening, the potential cost to patient and payers, and also the inconvenience of coming back and forth for IV treatments every 3 or every 6 weeks. So currently, we do have both pembrolizumab and sunitinib approved in this setting. I would probably warrant a guess that pembrolizumab is the preferred option over sunitinib for many of us on this stage and also in practice. But this was, Keynote 564 was the first one of all the adjuvant trials to show an overall survival improvement, and we'll look forward to seeing that data on Saturday. Additional data and outcomes from these ongoing trials will be important, and I do think that we need to think about the patients who are at the highest risk when we're having these conversations of the patients who might benefit the most. And with that, I'll turn it back over to you, Monty.
Tian, that was just terrific. Great overview of the adjuvant landscape. So we're going to start with a softball question. But remember, the softball questions are really for the other RCC program, right? We do all the hardball questions here. But let's take the case of a 68-year-old patient who presents with gross hematuria. He has a CT scan showing a 10-centimeter left-sided renal mass. He undergoes a radical nephrectomy. The specimen shows that there's some renal vein involvement, so this is a T3 lesion. It's invading into the perinephric fat. Margins are negative. It's grade 3 with clear cell histology. I guess there is some rhabdoid and focal sarcomatoid differentiation. I think that would probably take this up to a grade 4. But the patient recovers well. Post-surgical imaging is clear. Tian, we'll start with you. Would you offer this patient adjuvant therapy?
You know, he's at pretty decently high risk with the T3 disease and grade 3 and sarcomatoid differentiation. I personally would offer at least and have that conversation with the patient about adjuvant pembrolizumab.
And within what window would you want to start that therapy?
Yeah, I usually talk to folks within 3 months of their surgery, and I'm seeing them and having that discussion about what the pathology showed, and looking at their Assure nomogram, thinking about baseline risks of recurrence, and then thinking about what a year of pembrolizumab might do.
So Pedro, it took a little while for this patient to get to. It actually took him 6 months to find his way to your clinic. In this scenario, would you still offer adjuvant pembrolizumab?
Yeah, that's a great question. So of course on study we're not doing that, so we're kind of going there. But assuming the scans are still negative and considering all the risk factors that Tian pointed out, I probably would still have the discussion, explaining him, hopefully scans are negative, and explain there's still a good chance, especially now that we know survival advantage. I think that conversation probably would occur in my clinic in that scenario. Patient coming to me 4 or 5 months, after nephrectomy, and not within the 12 weeks that Tian mentioned.
And it's 6 months, so the answer is
I would
yes.
have that conversation, explain that's not really what we did on study, but nonetheless, thinking the high-risk features, sarcomatoid differentiation, addition to the T3, as you said, stage 3 disease there, I think it's fair to say, it's clear cell, right? I do think that's a conversation I would still have.
Okay. And Dave, the patient's trying to get into your clinic, takes a really long time. He sees you after a year follow. You're super popular, we all know that. So it takes a year to get to your clinic. Would you offer adjuvant therapy at that time? Patient still hasn't recurred based on recent imaging. What do you think?
Just to be clear, it takes 7 days to get into my clinic. They keep track of these stats in my place.
Okay.
Probably yes. I'm not sure we know the answer to that question, as Pedro was saying. But to me, the issue, as my colleagues had said, is more the biology than the stage, which is in Checkmate 914, which Tian discussed, which was a negative trial. Bob Motzer subsequently talked about what predicted for a better outcome, and high-grade PD-L1 status sarcomatoid patients all did better in that negative trial than those patients without those features. So this person likely has all 3 of those features, I would imagine. And because of the biology, I would offer the therapy, I think.
And give us a good cutoff. Let's take away the sarcomatoid component for a second. Let's say this was just a pure clear cell patient. And if they came into your clinic a year out, 2 years out, when's that point at which you would say, adjuvant therapy is probably not relevant?
If I'm being arbitrary, I would say 2 years. That's usually the time when we scan people less, if they make it to that point. Mm-hmm. By that point, you've probably excluded someone with a very aggressive recurrence. Mm-hmm. So I'm okay in that setting, not treating, but we haven't had too many of those patients yet. I personally haven't had any, so I don't really know how I would manage the patient.
Yeah, it's interesting. I found this really only happened right after the approval of adjuvant pembrolizumab, where you had those patients who you might have been following that were resected who came and said, well, what about this for me, right? So, you know, it does come up on occasion. So let me ask you, Tian, you go to your pathologists, okay, you have the pathology re-reviewed at UT Southwestern, and they say, wait a minute, this initial read on pathology, all wrong. It's not clear cell with sarcomatoid features. It's actually a papillary renal cell carcinoma. Would you offer this patient adjuvant therapy with pembrolizumab for that?
Well, technically, you know, we were talking about the not on trial approaches, and you know, with papillary, we also did not enroll them on these clear cell trials, and so I would have the conversation, but I don't think they would fit, and the benefit would not necessarily be there. So I have not treated with adjuvant pembrolizumab for papillary renal cell.
I've kind of done the same. You know, Dave, I'm going to throw this one to you because you had some very compelling data from Keynote 427 for pembrolizumab's activity in papillary. I mean, is this something you would consider in a papillary patient?
Probably not. I think we should do the trial. You know, I think Merck should do it and enroll it. There's rationale for it because the response rate to single agent pembro in the metastatic setting for those patients was 25%, so it's worth doing. And you guys have proven that you can accrue trials for non-clear cell patients over the last several years. Whether we can do that in the adjuvant setting remains to be seen, but I think we should give it a shot.
Very good. No, I completely agree with you there. And Pedro, I'm going to turn this question over to you.
Sure.
You take it to your pathologist at Case, and they say, "Wait a minute, UT Southwestern was way off. This isn't papillary. This is in fact a patient with chromophobe histology, pure chromophobe." Would you offer adjuvant therapy in that setting?
I would not. I would follow observation, and I do think, to your point, David, that I do believe that trial is ongoing. I found out in my search to put it together for that pembro versus placebo for patients specifically with papillary RCC. It's like 300 or 400 patients. I get the NC, at least on clinicaltrial.gov. I don't know who's the sponsor. For specific for papillary, not chromophobe.
But do you think that trial is big enough to answer the question?
That's a great, fantastic question, right? Because they also take disease-free survival as the primary endpoint. I believe it's around 400 or so patients. You know, so it's a fantastic question. And I mean, to your point, we have to do it. We have to prove it. You know, but thus far, I don't think we have data to support that beyond clear cell, especially chromophobe, for example, to your point, Monty.
Yeah, no, I've got to agree with you there. So Tian, you know, you're doing your physical exam on this patient. Let's pretend this patient just has pure clear cell histology. Okay. Actually, let's leave it those sarcomatoid features. Okay. Patient presents to your clinic within that 3-month window. So this is more of a standard adjuvant scenario. But you notice on physical exam, they're itching a lot. You see some skin plaques, and they say, "Oh yeah, doc, I've got some psoriasis." They've never been on biologics for it. Would you offer adjuvant therapy in that setting?
Oh, it's a really interesting question, actually. With you know, I would have a conversation about how well controlled their baseline autoimmune disease is, if they're on any systemic steroids. I think my threshold for potentially challenging with checkpoint inhibitors is if they're not on systemic steroids and not on disease-modifying agents. We have a conversation, and this is an approved treatment. It may flare up their underlying autoimmune disease. But there are people who want to take that risk. And I would put in a plug, there's an ongoing trial that the NCI is actively enrolling to, where patients with underlying autoimmune disease are being enrolled and treated with nivolumab, not pembrolizumab, but and hopefully we'll have that conversation and data to show that people who have underlying autoimmune diseases can, in certain circumstances, still be presented with immune checkpoint inhibitors.
I gotta admit, I didn't actually know about that study. Is that sort of across indications with?
It's across indications where nivolumab is a standard treatment.
Oh, very good. Okay, I think that's going to be really interesting. So, you know, one scenario that we don't address later, so I'm just going to go ahead and bring it up now, is the scenario, and let's take a patient like this. Let's say they go through their nephrectomy, and about 10 months later, they actually present with an isolated lung metastasis, and you say, gosh, this is a perfect opportunity for metastasectomy. So 10 months out, you remove a lung tumor, and that particular patient, if the pathology, again, shows clear cell RCC, would you offer adjuvant therapy?
Sure. I think, that patient would fit under the M1 NED patient population, right? Metacystectomy within a year of their initial nephrectomy. And that's the population where we see the disease-free survival benefit to be the highest. Now, I have colleagues who will say, well, are we treating early versus late? Should we be waiting until more disease? Is there micrometastatic disease? Should we be waiting? But I would at least have that conversation of adjuvant treatment, and this patient population would have benefit.
Same scenario to you, Pedro, but let's flip things just a little bit here. Let's imagine this particular patient presents to your clinic 2 years after having their initial kidney surgery, has a metastasectomy. At that time point, would you potentially recommend using adjuvant therapy?
Yeah, that's a great question, because obviously the longer it takes between the completion of, or the nephrectomy in this case, and then the recurrence, the more you think, you might have better outcomes, right? And the tumor might be more angiogenic in nature, and you're actually off what has been explored in the adjuvant trials. So I have to say that probably would address definitely local therapy, and then I would feel okay watching that patient. Also depends on the location of the met, for example. I think it's different if you see a solitary pancreatic spot versus a lung spot versus a lymph node versus a liver thing, because that, we know that's the location of mets also predicts biology and helps us understand a little bit more what might happen in the future. So taking that into consideration, I would say that probably 2 years later, one spot, let's say in the lung, I would probably think either resection or SBRT, and I might watch that patient. Now, if the patient's sarcomatoid, et cetera, we will still have the conversation, even though, probably would tend to watch that patient. But I would take anyone offering an ERF member. I don't think is unreasonable, but I probably would still do an extra surveillance on that case.
I'm kind of with you on that one. I'd probably lean towards observation in that scenario. Guys, don't forget to answer some of the blue survey questions popping up on your iPads. And now I'm going to actually turn it over to my dear friend, Dr. McDermott, who's a professor at Beth Israel Deaconess Medical Center and, of course, World's Authority in Kidney Cancer.
Okay, thank you, Monty. Glad to be here. Thank you all for coming. So I'm here to talk about how we choose from the bounty of first-line options that we have. Lots of exciting data with updates here at this meeting. I'm a little bit older than my colleagues here, on the stage, and I remember when things were not so good for our patients. So before 2005, before we had targeted therapy, before we had PD-1 therapy, outcomes for our patients were exceedingly poor, as you can see here. Combination of investigators, patients, patient advocates, industry have really led to a significant improvement in outcomes for patients, as you can see, both with the introduction of VEGF about 15 years ago, and now PD-1 blockade and those combinations. Essentially, by me bringing PD-1 from the second line to the first line, we've seen major improvements in long-term outcome, which I'll talk about today. So here are the data from 4 of the trials that have shown a survival advantage in the front line for our patients. They sort of fall into 2 flavors, the sort of dual IO therapy where we're blocking both PD-1 and CTLA-4, and the IO TKI variety where we're blocking PD-1 and VEGF. Most of them are in that second category. And they've all shown significant improvements in overall survival. Different outcomes, though, depending on which endpoints you're focusing on, with the VEGF TKI combinations generally improving those early outcomes like response rate and PFS, and the IO therapy having more impact later on the tail of the curve. So we're going to talk a lot tonight about the sort of the shapes of these curves. This is the Keynote 426 trial, which is pembrolizumab and axitinib. All of these trials had sunitinib as the control arm, and while we shouldn't really compare them to one another, we can compare them, I think, to how they did against that control arm. And what you can see here, and this was very impressive data when it was first presented about 5 years ago, maybe 6 years ago now at this meeting. Pembro-Axi clearly beating sunitinib as it relates to progression-free survival. That benefit, now that we have 5-year data, is still with us. Overall survival, similar story, an improvement in overall survival, those curves starting to come together as we get closer to 5 years out. Checkmate 9ER, which is nivolumab and cabozantinib, a very similar story as well. You see clear early benefit with response rate and progression-free survival. favoring nivo and cabozantinib. That benefit also translates into an overall survival benefit. The last time this data was presented, we saw almost a 12-month improvement in median overall survival with the combination compared to the last time we saw this data with nivo and cabo. And later this weekend, Dr. Borland is going to give an update of essentially the 5-year data from this trial, looking at the combination, and many of those same themes are going to be in this presentation, with clear improvements in median progression-free survival and overall survival continuing, as is response and complete response as well. So more to come on that, no new safety issues. In general, most of the safety concerns with these combinations have been pretty well established, and we'll talk about that in a few slides. The CLEAR trial was sort of the third in line of these VEGF-PD-1 combinations. In general, very similar themes, looking at clear improvement in progression-free survival, also improvements in overall survival. Once again, as you get longer out with overall survival, those curves are coming together somewhat, which we can talk about if you want. But in general, this trial probably has the best early endpoint results as it relates to response rate and progression-free survival of all three of these trials. There's going to be an update on this as well. Dr. Grunwald is going to be presenting on Saturday the subgroup analysis for this trial. Essentially what they looked at was how bulk disease translated into outcome. And not surprisingly, just looking at tumor measurements, if you had relatively less bulky tumor, you had a greater chance of response and longer progression-free survival compared to patients with higher burden of disease. Also, not surprisingly, the patients with relatively low burden disease were more likely to be in that favorable risk category by IMDC, where we know that VEGF is probably the most active. So essentially, when you look at these trials, like I said, we shouldn't compare them, but we often put them all together, on a slide. But essentially, the message for most patients is they're going to be living longer if PD-1 therapy is part of their initial approach. And there are different trade-offs with these approaches. As I've suggested, most of the general results with VEGF and PD-1 are pretty similar. But the IO-IO combinations have some differences, both good and bad, when you compare them to VEGF-PD-1. So here's the data for Checkmate 214. This was actually the first trial to read out. So we have the longest follow-up here. We're looking now not just at the intent to treat group, which is what we looked at in the previous slides, but also by IMDC risk category. And what essentially you see for Checkmate 214 is with Ipi-Nivo, there was a survival benefit for the entire population that was greater in intermediate and poor risk. It was not seen in the favorable risk, and that is one of the reasons why Ipi-Nivo is not approved in that subset of patients, which is a pretty large group of patients. Ipi-Nivo is only approved for intermediate and poor risk. But the interesting thing is that over time, those curves have come together and are now somewhat crossing, suggesting that there are some patients in the favorable risk group who do get a long-term benefit, both as it relates to progression-free survival and overall survival. Here's that progression-free survival that I alluded to before. Once again, you see a benefit in progression-free survival in the intermediate and poor risk group that doesn't meet statistical significance. In the favorable risk group, you see that crossing of the curve. So clearly, sunitinib was benefiting early for those favorable risk patients, but over time, there are patients who get Nivo-Ipi that catch up, that are essentially out there on that tail of the curve, which seems a little bit more flat than others, the VEGF-PD-1 combinations, suggesting that there are patients who are benefiting, and that benefiting is lasting multiple years. This data is close to 5 years. The data we'll see on Saturday is now out to 8 years. So while responses are less with IO-IO and PFS is shorter with this approach, probably the most clear distinguishing benefit is that if you have a response to this approach, it's more likely to be durable. And here you're looking at the confirmed response rates and the duration of those response rates. That durability can last over 5 years. And particularly the deeper the response, the more likely it is to be durable. So, and in that translates often to improvements in quality of life, because many of those patients are not just alive in response, but they're often off therapy. So the trade-offs are more early responses, more responses with VEGF-PD1, but if you're fortunate enough to have a response with a PD-1 CTLA-4, sometimes it can be durable, and sometimes you can see remissions with that therapeutic approach. So Dr. Tanier, as I sort of alluded to, is going to update this data with now 8 years of follow-up, and similar things will be seen. You don't see clear improvements in progression-free survival, but now the overall survival for the intent-to-treat population is over 52 months, which is pretty cool for our patients. Response rates have been maintained, and you can see the median duration of response for the intent-to-treat group is 76 months. So that's pretty good for those patients fortunate enough to get that response. Unfortunately, we're not really great at predicting before treatment who's going to be in that subgroup of patients, and there's certainly not enough of them in that group. So just these are generally my thoughts about how to look at this long-term data. I'm glad to hear the thoughts of my colleagues, obviously, because they probably have differing opinions. But as I've sort of alluded to, for the PD-1 CTLA-4, we see improved overall survival. We see the longest follow-up. Those durable responses drive a lot of that durable benefit. And there is the potential to stop therapy in some patients, which can lead to improvements in quality of life. But there's no question that for that benefit, there is significant risk. There is certainly more higher incidence of IRAEs, which we'll talk about in a second, which can be life-threatening and life-shortening. There also are lower progression-free survival rates, lower response rates, a higher rate of progression of disease is your best response. So for patients with active symptomatic disease, it's often not the best approach to get control over the disease. And the opposite is true for PD-1s and VEGF. So there, once again, you see overall survival benefits, but they are driven by a higher early benefit with response, less progression of disease initially, far less, a longer progression-free survival, and a significantly lower adverse event rate, where the adverse events are easier to manage. We'll talk a little bit about some of the negatives, which are the overlapping toxicities. Sometimes you're not sure with PD-1 VEGF what is driving, for example, the diarrhea. And there's also some potential for chronic toxicity, but there's less potential for toxicity that continues after the treatment stops, which is very important for patients, it's great that the benefit can continue, but sometimes the toxicity can continue for months and years afterwards. And because of that downside of immune therapy in general, regardless of the approach that you take, we tried to develop this model we call treatment-free survival, which is a way of sort of partitioning patient survival over time to get a sense of great news is that patients live longer, but how do they spend that time? Are they on the protocol treatment? Are they on subsequent treatment? Are they dealing with toxicity? And because IO therapy can be associated with both good and bad that lasts after you stop treatment, we thought we would develop a model that would help tell us as we add more therapies, are we adding more good, or are we adding more bad, or both? So this is sort of how that partitioned survival model looks. You can see overall survival at the top is measured as it would be in a standard Kaplan-Meier overall survival curve, but then the different subgroups, where in purple you're on protocol therapy, in blue you're off the initial therapy and you're living in treatment-free survival, and in gray you're surviving but on the subsequent treatment. And those sort of hash marks are the time you're spending in those categories with side effects of treatment. So when you do a treatment-free survival analysis for Checkmate 214 after 5 years, well, you can see a few things. One, as we've talked about, Nivo and Ipi produces more survival than sunitinib for the intent-to-treat group. But during that survival time, the patients are twice as long to be alive off treatment. But they're having more toxicity during both the time they're on drug and the time they're off therapy. So there are trade-offs for our patients. And what we think this helps us with is that initial patient discussion, so that when you're trying to decide between Nivo-Ipi, say, and Pem-Len or something like that, you can give people a sense of what they might expect, both as far as survival risk and the time that they would spend alive, but also with the toxicities as well. So they can get a sense for themselves of the trade-offs of treatment. Tien mentioned this before. We're learning a lot about who gets immune-related adverse events, who's at risk, and who's not. We're also learning a lot about the timing of these adverse events. There tend to be some patterns which emerge, although not every patient follows this sort of textbook. We try to, based on the onset, we try to educate patients about the potential of when these side effects might emerge, what to watch for, how long these might last, when to call us. So for example, I'm often seeing my patients more than once in the first month of treatment, because some of my worst outcomes have happened very early on with treatment, and that educating patients can actually help improve their adherence to this. As far as management of toxicities for IO plus TKI therapy, in general, there's less toxicity to manage, which is good, but sometimes they can be overlapping. As I mentioned, some of these drugs, both PD-1 and VEGF, can cause rash and can cause diarrhea, can cause hepatitis. So when you're seeing those, the question is, which drug is driving it, which drug should you stop? The advantage with some of the VEGF approaches, particularly axitinib, is the half-life is short, so if you're concerned someone's having diarrhea, you can stop the axitinib, and within a couple of days that will get better if it's the axitinib driving the tox. Whereas if it's, say, the pembrolizumab, the diarrhea will persist and you need to consider steroids or other therapies. As far as next steps in this first-line space, we talked about how doublets with PD-1 are now the standard of care. Investigators are actively building on these doublets, looking at triplets. This is one of the first trials of a triplet to read out. This is Ipi-Nivo versus Ipi-Nivo plus cabozantinib, the so-called COSMIC 313 trial. This is a very well-executed and important trial, which showed a clear benefit for one of the primary endpoints with Cabo-Nivo-Ipi. You see that clear benefit in progression-free survival, but also more toxicity. So the question there is the trade-off worth it? We've yet to see the overall survival results. If this does translate into an overall survival benefit, this will likely become an approved triplet combination. If not, maybe not. But there are other investigators that are looking at other combinations, which we also have some we're looking forward to. One is the LIGHTSPARK-012 trial, which is looking at belzutifan and lenvatinib and pembrolizumab, and Merck's version of CTLA-4. Tien is leading the Pedigree trial, which should help us look at different combinations and whether we can adjust treatment based on treatment response, which is an exciting trial that's continuing to enroll and should finish enrollment later this year. So also, obviously when we're making decisions, we need to take in the patient's viewpoint. The Casey Cure folks are always giving us great insight into what patients like. This is, some recent results from patient surveys looking at how, patients adjust to side effects and what's important and whether adjustments are being made. And when you look at some of this data, what you realize is we have more work to do with not just educating our patients, but communicating with them and helping manage their side effects. Because for example, one question here was the dose reduction helpful? And not every patient finds that when we talk to them, when we survey them. And the same thing with the dose reduction of treatment was, when you made that dose reduction, did you feel relief? Were you worried about reducing side effects? It turns out that a lot of our patients, reducing dose, a lot of our patients are sort of conflicted about talking to us about dose reductions and stopping, and oftentimes that drives unnecessary toxicity. So encouraging patients to report adverse events right away is probably better at the adverse event management. And with that, we're on to a case, which means it goes back to Dr. Paul with a minute to spare.
That's right. Excellent job. Wonderful overview, Dave. I actually asked the peer review folks to give me a little bit of laxity here so I could really run with the clinical scenario, which I probably would have done anyways, frankly.
We're seniors.
But this is a 68-year-old gentleman, once again. Let's say they show up to your clinic, TN, okay? And this is the week after ASCO GU. You really walk them through the pros and cons of a scenario in which the patient has intermediate risk metastatic renal cell carcinoma, talk them through IO-IO versus IO-TKI. The patient, for a variety of reasons, sides with IO-TKI and turns to you and says, well, doc, what's the best IO-TKI regimen?
You put me on the spot. There are 3 approved options. Actually, there are 4 approved options, but the most common that we would use in our clinics are axitinib, pembrolizumab, lenvatinib, pembrolizumab, and cabozantinib with nivolumab. I often, in terms of sequencing treatments and of the sort of massive amount of data that we have about cabozantinib in the refractory setting, I do think more axitinib pembro or lenvatinib pembro in the frontline setting if I'm using IO-TKI to use cabozantinib for later. But it's certainly also worthwhile to use cabo with nivo. I'm really excited to see all the data that's coming out on Saturday.
Yeah, I'm kind of curious about that. Of course, we've got to wait until we see the shape and look and feel those Kaplan-Meier curves. I've always been a little skeptical of the principle of waiting, and saving treatments for second and third line, because we never know if our patients are necessarily, unfortunately, going to make it to that setting. So I've really been a fan of siding with cabo-nivo first. It seems to me, and Dave, maybe I'll ask you to comment on this, that the data seems to be kind of holding up over time, right? And why do you think that's different from what we're seeing with axi-pembro or len-pebro, or will it evolve to be the same?
Yeah, no, it's a good question. I'd like to see more of the data than the updated curves and see what they look like. It's possibly the behavior of the combo. That would be the positive explanation, that there's something about the nivo-cabo combo that allows that benefit to last better than we see, for example, with len-pembro. But it also could be the performance of the control arm in that study, too, possibly, with the sunitinib folks maybe not doing as well. So, to me, I think all 3 are active. People get comfortable with a certain regimen. I personally am comfortable with giving nivo-cabo, in part because we have given it so much in other scenarios. I think reducing the dose helps. Patients tolerate it. Whereas with lenvatinib, it's certainly a very active regimen, but I struggle to get it into patients at the dose that it's approved. So that's probably the reason we use less of it, but that's more about clinician convenience than anything else, because the outcome data of the CLEAR trial is clearly impressive too. So that's just my opinion.
Pedro, let me ask you about that, just building on what Dave just said. It's always been curious to me that, we see this really sort of marked PFS advantage with len-pembro in the CLEAR trial, but then the overall survival hazard ratio seems to be pretty much akin to what we see with the other doublets, and again, we have that phenomenon of the curves coming together. Why is that?
Yeah, it's a fantastic question. By the way, just to get back, I agree. I think we getting comfortable to a regimen is probably part of the secret, right? And the other thing is to David's, if we've been around enough, we know that, there are a low but real chance of cure in some patients. And so for those who really believe in immunotherapy, like thinking of the question, is this a patient we're doing a dual IO-IO, it's reasonable, and we have time to actually do that. I think that's the right strategy. A lot of us say, what is the patient is not a good candidate for an IO-IO, and I do also favor cabo-nivo in the cases where I do believe that a TKI is a good opportunity there to be added to the IO. With that said, I don't know. I think the meta-analysis do point exactly to your point, Monty, that we see that we can see more response rates. The IO-TKI tends to give you about 20% or more or so compared to IO-IO, and then the PFS, there's some differences, right? We're talking roughly about 2 years versus a year and a half. If we think of the ones who achieve absolute numbers that higher, like len-pem and cabo-nivo in those cases, but then we don't see much of a difference in terms of median survival. Now, things like access to sequence therapies, and remember, these are all international trials, and so access access to subsequent therapies might also matter. I think it's very difficult because, we lose patients as we move from one line to the other. So I think there are certain factors we certainly don't control. Another factor we don't control is exactly what is the tumor signature. In other words, we're not really accounting for that. We all assume that randomization will take care of that, but I don't think we quite know that for a fact, right? So so with that said, I guess it's a long-winded answer to say I don't quite know, but that gives us reassurance that if you go with a combo versus a different one, you are doing the right thing. And that is really the message, is offering an IO-based approach for most of the patients that come to see us with advanced clear cell RCC compared to TKI monotherapy.
But in less than 5 seconds, what TKI-IO combination do you use up front?
I use Cabo-Nivo when I do Februer, yes.
Okay, so we're going to move on to the next section here. Take a moment if you don't mind.
The moderator approves that answer.
I am the moderator. So we'll take a moment to answer the questions on your iPads there, and then we're going to move into what I think, again, is going to provoke a lot of interesting discussion, which is talk around refractory disease that Dr. Barata is going to lead us through. Dr. Barata is an absolute superstar in the field who's at Case Western, running a lot of really fascinating trials, some of which I'll highlight in my talk, and he's going to talk to us about refractory disease.
Thank you so much, Monte. So it's such a pleasure to be among, really stars and guys who have done a lot for this field and for patients with kidney cancer. So happy to be here. It's kind of a nice story, right? We started with adjuvant therapy. We move on to frontline, advanced disease. And the question really is, unfortunately, we're not able to cure the majority of those patients, or at least offer long remissions. And so unfortunately, these patients will need subsequent therapies. And that's really what we're going to spend the next couple of minutes talking about. Of course, how you get there matters. If you can get there progressing on IO, on a TKI monotherapy, like sunitinib, cabozantinib, pazopanib, you can get there after progressing on IO, in this case, ipilimumab, nivolumab, or you can get there after receiving an IO-TKI combo. Of course, the options we have available change depending on the treatment you were exposed previously, and we go through that data a little bit, but for patients progressing on IO-TKI, we do have data with the PD-1 in the second line monotherapy, or also data with Cabo in the Meteor trial. Then for patients receiving ipi-nivo end up progressing, I think we'll show a little bit of data to support the TKI monotherapy, probably Cabo in that scenario. And finally, for patients progressing on IO-TKI, an alternative TKI is probably a very reasonable approach. So why is that? So before I get there, just to remind, again, the great elegant survey put together by Casey Cure, highlighting over 30% of patients with advanced disease, over 1,000, so big study. And I think it's quite telling that actually over 2/3 of patients tell us that they're actually not aware of risk status is. And just a reminder, this score developed by Dan Heng and many others, the goal was to understand prognosis based on a multivariate analysis of characteristics measured up front, right? It was done in the TKI era, if you will, so a long time ago, but we've embedded the categories of intermediate good and poor risk, or intermediate poor and high risk, in all the phase 3 trials we've been measuring today. So, but it's quite telling that actually almost 70% of patients are not aware of that because they didn't have that conversation in the clinics. And what's also telling to me, at least, is actually the concept that patients have about long-term response. What do you mean by long-term response? And perhaps what we mean by long-term response is very different to what this survey is telling us. Because if you look at the numbers, you can see actually that 70% of patients think that long-term response is responding 5 or more years, and actually a quarter of them thinks that long-term response is being without progression for over a decade. Right, and this is quite telling. I think this speaks a lot about, our concepts might mean different things for patients we're trying to treat. And finally, when we go around thinking about therapy for advanced disease, and you ask the importance of the goals that you want to achieve, the number one seems to be chance of eliminating cancer. It's basically cure, right? Long remission / cure. And at the very least, it comes the cost related to therapies being more affordable. So I think this is very, very informative information for us to have as we treat those patients. So with that said, I'm just going to go through a couple of data sets that I think are relevant when we think of the refractory setting. The first Cabo point, very elegant work presented presented by Laurence, Dr. Albiger, basically 2 cohorts of patients progressing on, an IO-based approach, IO cohort A and IO-TKI cohort B. And you can see there on the right the activity measure here in terms of response rate seems to be a little bit higher for patients progressing on IO because they are TKI naive patients compared to IO-TKI. Nonetheless, I think this validates the concept that indeed cabozantinib is perhaps one of the most active TKIs out there, and it's important to see that in the post-checkpoint inhibitor era, because that's what we do today for most of our patients. The second study that's relevant, and a lot of us do this in the community, is actually use a very active combo, lenvatinib combined with everolimus. So we all know that lenvatinib is also a multi-TKI kinase inhibitor combined with an mTOR inhibitor. So everolimus kind of lost traction as monotherapy. This is one of the reasons why it's shown to be inferior to actually lenvatinib everolimus. In the same study, by the way, lenvatinib was also shown to be more active than everolimus, and perhaps one point here is these patients progressed on a prior VEGF therapy, so there was some comments about we want to see this data in the post-IO setting, since we're moving the immune checkpoint inhibition early on to first line. So this data is actually being utilized in the community to offer to patients. And with that said, I also should have mentioned that actually there was a dose-finding study that Monty led those efforts, understanding exactly the right dose is, 18 or 14, along with everolimus, and that it was a non-inferiority study which did not meet the primary endpoint. So in other words, it appears that the activity seems to be superior with the standard combination dose that was approved, and with no benefit in terms of safety when you look at the lower dose. So if we want to use the combo, we should go ahead and use actually the dose that has been tested in the Moser study, in the 3-arm study that I just showed you, about 50 patients or so in each arm. So moving on, then you have a very important, in my opinion, phase 3 trial. It brought us a new TKI, which is a selective and potent VEGF TKI in the refractory space. It's tivozanib. It has a long half-life, and it has been explored in the refractory setting for patients who have progressed on at least 2 systemic therapies, and that's important, at least 1 VEGF TKI. The progression-free survival is the primary endpoint, and indeed, the results do favor tivozanib. Tivozanib was shown to be superior compared to sorafenib in this particular trial. We're talking roughly 38% or so risk reduction. What is also relevant when you look at the long term, at the time at 3 or 4 years, it's interesting because you still identify a subset of patients who have been gone on tivozanib, without progressing. And I think that speaks from 2 components. One, there's patients out there to have long benefits to a TKI, in this case to Tivo, and the second is the safety profile probably favors this long-term therapy as patients continue with preserved quality of life and have tumor control. So I think that's important. What's also interesting is to see the behavior of the survival curves over time. We see that although the survival was not positive, we do see a trend in the right direction, perhaps driven by the patients that remain on therapy longer over time, right? So you see that trend coming down in terms of hazard ratio, and the most recent one that we've seen was like 11% reduction. Again, not statistically significant. Nonetheless, we see the hazard ratio dropping and separating, or going down and separating from 1. So I think the long-term follow-up kind of seemed to be in line with it and kind of established this therapy for patients with refractory, RCC, again, progressing on 2 systemic therapies, 1 being a TKI. Important to highlight the safety. For those of us who actually use this in practice, we do see this as a very safe option out there. We do care about high blood pressure. It's perhaps the dominant side effect we've seen. We do see, fatigue certainly doesn't seem to be more than the sorafenib in the Tivo 3 trial. But it's really the high blood pressure, the one that comes to mind. Nonetheless, we do see less dose reduction and dose discontinuation interruptions, despite those patients have been on longer term on tivozanib compared to sorafenib in the tivozanib arm of the Tivo 3 trial. So switching gears a bit, so when we go back 5 and 6 and 7 years ago, we were, all excited about with the emergence of checkpoint inhibitors, and then we established that as new standard of care. And then the next question was, does it make sense with a salvage approach, right? Because at that time, we established Nivo first in the second line. We were emerging with Ipi-Nivo, and the question really was, is there a role for salvage CTLA-4 inhibitor? I think we got a number of studies who kind of helped answering that question. We became a little bit skeptical about that, so we understood that probably the right role for CTLA-4 inhibitor was in the front line. And then the next question was really, what about the salvage PD-1 or PD-1 inhibition? So with that, I'm going to highlight 2 studies. This is a work from Dr. Lee. It's basically a single-arm proof-of-concept phase 2 study offering patients who progress on a prior checkpoint inhibitor to be on lenvatinib pembrolizumab. So in this case, the single-arm study, everyone received lenv-pem, is actually quite provocative results, right? Responses around close to 50%, again, in the refractory PD-1, PD-L1 population. So it's very provocative, and these actually leverage, the investigation of salvage PD-1, PD-L1 in the refractory setting. And with that, I should highlight a very important study, right? We often say it's easier to publish positive studies, but that's so important sometimes as practice changing to actually report and show what we've done with negative studies. So kudos to Monty and Tony and the teams, because they did launch this important phase 3 trial that really asked the question, is there any role to add atezolizumab, a PD-L1 inhibitor, to standard of care TKI cabozantinib, compared to cabozantinib alone for patients with refractory RCC who progress within 6 months on a prior checkpoint? And the answer is really no. It's a flat negative study, but a super important study in my view, because it does clarify, at least for the PD-L1 inhibitor, that in fact there's no advantage of doing that because you have more toxicity and you don't get more efficacy with that approach. So very important piece of information. Of course, there were questions that were raised, and whether or not that's applicable to a PD-1 inhibitor remains to be seen. And with that, here's what we have. We actually have early data showing that combination of nivolumab, a PD-1 inhibitor, along with tivozanib is safe, and it presented promising results in this early study. It's actually leveraged a phase 3 trial called TiNivo-2. This phase 3 trial has not read out yet, but it has completed enrollment last year, and is basically asking not exactly the same question, but a similar question, which is, what is the role of a salvage, in this case nivolumab, a PD-1 inhibitor, in addition to tivozanib compared to tivozanib alone. So there's some nuances in here that make it different from the other one. The control arm in here has different doses of the TKI backbone. In a similarity to the other trial, the backbone is the same. We had the same TKI in both arms. It's very important when you want to assess the contribution of the second agent, in this case of the checkpoint inhibitor, right? And the other is we don't mandate, or the study does not mandate the progression within 6 months. So we will see how the data looks like as it reads out, but I do believe this trial combined with the CONTACT-3 will give some clarification to the field regarding the role of salvage checkpoint inhibition, in the refractory setting. So finally, I have to highlight, of course, the HIF-2 alpha inhibition. It's actually, we already know about this, not because of sporadic RCC, but what happened in patients with VHL disease, right? Where it actually got approved. It's actually a very elegant work, Dr. Jonash and others, New England paper. And so so the question was to understand, and by the way, there was a Nobel Prize around this that work at UT Southwestern, Boston, et cetera, have done on this. Now, what I'm going to clarify, what I'm going to highlight is really the early data for sporadic RCC. So these heavily pretreated patients who receive this belzutifan, or oral medication, in patients who, again, refractory clear cell RCC, and we do see quite interesting results. I think what caught our eye, in addition to see about 24% of patients responding, we actually saw median progression-free survival over a year. It was actually 14.5 months. This is data from Tony, which is quite interesting because over 70% responded for more than 6 months, and I believe over 40% of patients got 3 or more lines of therapy. Heavily pretreated population. population, this was quite striking results. So we were seeing not a huge shrinkage, but like these patients just stay on without progression. So very provocative, promising results. So all of us were really exciting to look at the data, presented from the LightSpark-05, where really the goal was to establish belzutifan as new standard of care for patients with refractory RCC. So that study happened. You basically enroll patients up to 3 lines of prior systemic therapies, randomized 1-to-1 to belzutifan and everolimus. This is a positive study. Here's the primary endpoint, progression, free survival. You have about 25% risk reduction, and you see here, you see the hazard ratio there accounts for the differences over time, right? So don't get lost by the medians, right? Because the medians are, quite similar there. However, you see the difference, and particularly for if you look beyond the 6 months, you do see a clear separation of the curve. So this is a positive trial, and actually end up getting approved about mid-December. So over a month or so right now. So it's now available for patients with refractory clear cell sporadic RCC, and that's very important because we have a new treatment option available to patients. The survival, we have not identified a difference. We have not seen a difference in overall survival yet. And this was a secondary endpoint of interest here in the interim analysis number 2. So where can we go from here? Where can we build upon this, right? And I think the answer might be in combination strategies, right? We've heard that combination strategy that Ian presented in the adjuvant setting combined with Pembro. So here's another strategy, right? It's, we're looking at data, here being presented. I'm just still showing you the secondary endpoints, but what I want to highlight is is the combination with the TKI. Here's data combining belzutifan with cabozantinib as LightSpark-003. We see quite promising results in here. You can see the time to events there, and basically that leverage the phase 3 trial LightSpark-11, testing the combination of belzutifan with with lenvatinib against cabozantinib, considered again standard of care for patients with refractory RCC who have received up to 2 prior systemic therapies. So I do believe this is a very important study as well, and we'll see what these data teach us. And with that, I'm going to pass the baton back to Monty.
Awesome, great job. Pedro, this is going to be an interesting component of the discussion. If you came to our peer review program at IKCS a couple months ago, we actually didn't have the data for the belzutifan studies at that point in time. So now we have this really great opportunity to talk through second-line scenarios. So I'm going to envision the patient, let's say, that has progressed on initial frontline therapy with cabozantinib and nivolumab. The patient then goes on to second-line therapy, let's imagine, with lenvatinib and everolimus, okay? What would you choose as their third-line strategy, Tian?
So cabo-nivo, then len-evro. Symptomatic, asymptomatic?
Let's go with that first scenario, symptomatic rapid tumor kinetics.
A hard case. I would think about any trials I had available in a refractory setting, and if they didn't fit trial criteria, we would probably think about, I think tivozanib is a very valid option in that sort of refractory setting based on TiVo-3. I think belzutifan is now a really good option too. And the thing I struggle with when I think about the patients who might respond to belzutifan is the people who respond extremely well, and they have these durable responses. So that interim analysis 1 and 2, over time, these people are getting more benefit. But it's hard to tell which patient population has those long-term effect from belzutifan. So I think either are good options, and I would potentially try them in sequence.
Yeah. So I'm glad you actually, asked about the symptomatic status of the patient, because I personally feel like that's a big deal here. If that patient needs to evoke a response quickly, as I would imagine probably most of our patients in the salvage setting do, I would probably side with tivozanib. If we think that we have, really sort of a long latency in the tumor kinetics, I might side with belzutifan there. But I have to tell you, sitting at ESMO, I wasn't, actually blown away by the data that I was seeing as I sort of anticipated for belzutifan. It just sort of fell short of some of the response rates and progression-free survival that we were seeing in the phase 1 experiences. Probably not something I should have been shocked by. And Dave, what do you think? Talking through this scenario, patient comes to you, let's change the scenario. They've got Nivo-Ipi up front, they've gotten Cabo next, okay, and they have a symptomatic disease. They need to get on next therapy fast and get a response. What are you going to suggest?
So if they've only seen one TKI, I probably would give them a second TKI if they were rapidly progressing, particularly, and it's hard to follow Tien because she always gives the right answer, but particularly if they were on a full dose of Cabo when they progressed. You know, some patients, if they come off Cabo or Lenva because you reduce the dose, then TiVo can be particularly helpful in that situation because I think it's easier to tolerate for many patients, particularly if they're beat up. But that's the only caveat I would say to what Tien said. But getting back to what you said about belzutifan, I just want to say for a second here, you know, if you just look at the numbers, the results are not earth-shattering, I agree. But the concept is really important, you know, meaning this is our first tumor-directed therapy in kidney cancer that actually hits the tumor. There was a long debate about whether HIF-2 is an important target, so belzutifan proves that it is, and you can hit it, and you can have a good clinical outcome with a drug that's much more tolerable. And getting to Tien's point, we need to absolutely figure out who are those patients who are going to benefit, because if we could get it in earlier for those patients, they would feel much better. Most people, when they switch from VEGF to HIF, they feel better, assuming their cancer can be controlled. So if you had a marker, you could bring it up, much in the way that BRAF is a marker for melanoma therapy. If we had a marker for belzutifan, I think that would make a big difference for patients. But ultimately, we need to build on it. It's surprising the response rate is only 25% if 80% of our patients have a VHL mutation. So why is that? But that, to me, you could look at it as a downer, you know, like, wah, wah, this isn't so great. Or you could say, well, there's an opportunity to get the response rate closer to 70 or 80%, either with a better HIF inhibitor or combinations or something like that. So that's, you know, me being the eternal optimist, that's what I would say.
No, that's totally fair. Pedro, I'm going to throw this at you. So the patient comes to you after having progressed on cabozantinib and nivolumab. You know, this particular patient expresses some interest in belzutifan, but you take into account the fact that only 12% of patients in LITESPARK-005 had received belzutifan in the second-line setting. Is this a treatment consideration that enters in to that discussion?
Yeah, so basically second line post-Cabo-Nivo, yes?
Yeah.
Okay, got you, yeah. So, I mean, I agree with those comments. I probably wouldn't, it depends also on how the patient is progressing, right? How, you know, when is the progressing occurring, right? Is within the median? Is it 3 years later? Is it within a year later or less, right? And, you know, how is that progression measured? Because, you know, if you're progressing with, let's say, you know, new visceral disease, new liver mets, you know, happening within 9 or 10 or 12 months, I'm worried about it. And I you know, and even though, yes, we do, this patient stay on belzutifan for a long time, I probably would feel more comfortable regaining control, perhaps with the therapy would give me more response rate in that scenario to regain control of the disease. You know, on the other hand, the patient might be beaten up, you know, let's say patient is getting a TKI, is beaten up from it, that could be a consideration I would take because the safety profile or the tolerability is completely different from belzutifan compared to another TKI. I'm just thinking that scenario, you know, I think TiVo would be an option, Bel would be an option, but also in that case, lenvatinib plus minus everolimus would also be an option, right? For example, if I get a bit later, you know, also the goal of the game at that point, I do think more about belzutifan then, you know, and I think the safety profile of those therapies being so different probably also helps me to decide. So symptoms, look, you know, how the patient is progressing, how quickly it's progressing, as David alluded to, you know, and also the tolerability of the two agents who are very different, right? As a patient has issues with, you know, lung disease, et cetera, right? Because hypoxia is real, you know, versus the other kind of TKI-based side effects.
Okay, so belzutifan's second line, probably not. That is what I'm inferring.
I do less so in my practice.
Yeah, I think that's fair. That's totally fair. So take another moment, if you don't mind, to answer these questions popping up on your iPad. I'm going to actually try to race through the slides in my section so we have a little more time for Q&A. And we've got some good questions coming up also in the chat, so please feel free to send some questions in and I'll see them register here in my iPad. So I'm actually going to focus on some new developments, and this is something that we're actually going to hear about at this meeting, subcutaneous nivolumab. Nivolumab has been approved globally for IV administration, as we all know, but there are certain advantages to sub-Q administration. I'm sure all of us at our respective cancer centers are dealing with issues of of infusion space and so forth. So I do think there's some merit to this. There's been a host of studies that have explored subcutaneous nivolumab. You can see this multi-part study that included renal cell carcinoma patients. And for the first time, we really have a randomized demonstration of standard intravenous nivolumab versus subcutaneous nivolumab. You can see here that the indication for nivolumab as a single agent really meets the setting in which we would typically prescribe it in previously treated patients. And so this study is going to be presented on Saturday by Sabby George. I look forward to it. We know that the co-primary endpoints were met. It looked as though nivolumab sub-Q is non-inferior to intravenous administration, which I think is compelling and makes a reasonable argument to at least consider it in clinical practice. I'm really excited about this compound, zanzalintinib. I've been working with this agent for a while now in the clinics. If you look at the TKI profile, there's some similarities to cabozantinib, although I don't think any two TKIs are necessarily created equal. It does have a much shorter half-life, and there's some PK/PD properties around this that I think really make it more amenable to dosing and perhaps better tolerated than cabozantinib. Last year at IKCS, I presented data from this study, STELLAR-01, which looked at patients with previously treated renal cell carcinoma, treated with zanzalintinib after a dose escalation at the recommended phase 2 dose of 100 milligrams daily. And I want to bear in mind as we go through this data, this was a very, very aggressive phenotype that we encountered in this study. 38% of patients with liver metastases, 34% of patients with bone metastases, 41% of patients with experience with 3 or more prior therapies, so bear that in mind. And this was really a contemporary population too. Almost everybody had gotten a checkpoint inhibitor previously. The vast majority had also gotten a TKI, and about half, and this is going to be the interesting part, half had gotten prior cabozantinib. So when you look at the data here, I think this is impressive, again, for an agent that's being looked at in the salvage setting for renal cell carcinoma. Response rate was 38% in this particular series. And this is what really struck me. There's still responses amongst those patients that had received prior cabozantinib, 24% in that cohort. If you look at those patients that hadn't received prior cabozantinib, response rate actually climbs to 57%. So this really does seem to stand out. And if we look at patients who had gotten a prior VEGF TKI who hadn't received prior cabozantinib, you see that the disease control rate actually extends to about 100%, which to me is quite satisfying. Now, STELLAR-02 is a study that's going to assess multiple cohorts. This is an ongoing trial that looks at zanzalintinib in combination with Nivo, Nivo-Ipi, Nivo-Rela. I think this is going to be really compelling and important to bear in mind that this doesn't just include clear cell renal cell carcinoma patients where you would anticipate activity with zanzalintinib, but also non-clear cell patients as well. And I think there's going to be a lot of interesting data coming out of this trial in the coming years. Now, what about combination therapy? We oftentimes reflect on the role of combination therapy in the clear cell setting. I wanted to just highlight very quickly for you some data that's emerging in the non-clear cell space. Me and Neeraj Agarwal and several others put together the data set for cabozantinib and atezolizumab. There's a lot of waterfall plots shown here. If you look at the data for cabozantinib and atezolizumab, response rate in papillary RCC, I think it's compelling, 47%. The response rate with cabozantinib and nivolumab as well, 47%. Bevacizumab and atezolizumab falls a bit short with a response rate in the 20s actually for papillary RCC. And then lenvatinib and pembrolizumab, we're going to see some updated data from Keynote B61, which looked at len-pembro for non-clear cell. I think actually this study has some legs, and it's going to be interesting to see how this bears out, hopefully in randomized designs in the future. I haven't seen that as yet. For all the investigators in the room, I could really use your help with this clinical trial. We don't have enough studies that really focus on patients with non-clear cell kidney cancer. This is the STELLAR-304 trial that includes patients not just with papillary RCC, which has been the focus of several studies that I and others have worked on in the past. This also includes unclassified histologies. It includes translocation-associated RCC. These are disease subtypes that I think are greatly in need of novel therapies. So the randomization here is to sunitinib versus zanzalintinib with nivolumab. You've seen the compelling data for zanzalintinib in clear cell disease. There's accumulating data in non-clear cell as well. Now, in the last portion of my talk, I really wanted to kind of veer into uncharted territory here in renal cell carcinoma and really suggest to you that there might be some cool pathways and mechanisms that we haven't yet explored. My outstanding fellow, Nazli Disman, who's now at MD Anderson, did this first study with nivolumab and ipilimumab plus or minus CBM 588. Now, CBM-588 isn't a targeted therapy. It's not a checkpoint inhibitor. This is actually a microbial construct that enters into the lower gut. It's a spore form of Clostridium butyricum, starts producing butyrate in the lower gut, and we think that augments the immune response. And she demonstrated that very nicely in a Nature Medicine paper that she led. I have an outstanding fellow in the audience, Dr. Hedya Ibrahimi, who actually led the second study that you see there, cabozantinib plus nivolumab, with or without CBM-588. And it was demonstrated in that study as well that we see an improvement in progression-free survival over the control arm of cabozantinib and nivolumab as well. So she's putting the finishing touches on that manuscript, which she presented in a terrific session at ASCO last year. And of course, we do these small studies within institutions as ISTs. It's all fine and dandy, but we need somebody to take it across the finish line. So I'm very grateful to Pedro Barata, who's actually developed a SWOG proposal that I think is actually moving along fairly quickly, that's going to be looking at IO-based therapies plus or minus CBM-588 in a definitive phase 3 clinical trial. So really excited to see how this pans out. We're exploring anything and everything at our institution that we think might potentially modulate the gut microbiome. I think this is perhaps an area that we've overlooked in recent years. I have an outstanding fellow from Mexico City, Dr. Regina Barragan-Carrillo, who's here in the audience tonight as well. So Regina has actually turned her attention to camu-camu. So just by show of hands, who here has heard of camu-camu before? A couple of folks. I actually hadn't heard of this, but my dear friend and colleague Bertrand Rudy from the University of Montreal has this terrific paper in Cancer Discovery that showed that you can actually take an isolate from camu-camu, this natural product, and really augment the impact of immunotherapy in mouse models of melanoma. He's actually starting a study in melanoma in Canada, and it's up and accruing, that looks at this exact same phenomenon, nivolumab and ipilimumab with camu-camu. Here we've done a small randomization as we have in our prior studies. So Dr. Barragan-Carrillo and I are in the clinics day to day, recruiting for this particular clinical trial. Again, it's one that we could use help with if you have patients in the Southern California area. What else are we doing in the RCC space? I am really interested in cellular therapies for RCC, as are many of my colleagues up on the stage today. I've been working with a compound called CTX130, which is a CAR T construct that's targeting CD70. This is a very pervasive antigen in renal cell carcinoma. And it didn't work in everyone in a preliminary study that we did with 14 patients, but I actually treated the patient that's at the top of that swimmer plot there. And this patient actually had a CR after frontline therapy with cabozantinib and atezolizumab in a phase 1. And I'm really pleased to report that that CR has actually been maintained now at 3 years. So, I think there's some legs to this CAR T-cell therapy approach. We still haven't got it perfectly right yet, but we're working on it. ADCs, it's hard to come to an oncology meeting these days without hearing about ADCs. Certainly many fascinating ones, I think, being developed in bladder cancer, but there are some ADCs currently in use. We're working with many others on this trial, looking at PRO1160, which is an ADC that's directed to CD70 as well. I wanted to wrap up here by highlighting an abstract that I think is really of critical importance. We focused a lot tonight on recommendations that we might offer to patients. I think that many times our recommendations are substantiated by what we either perceive from looking at toxicity data or maybe looking at quality of life data. Pedro alluded to the fact that we'll see some quality of life data for belzutifan presented at the meeting this time around. I just wanted to spotlight this work from my outstanding fellow, who's now actually a faculty member in Brazil, who's doing a ton of fantastic health-related quality of life work. She developed this 3-part study in which she first engaged about 200 patients at City of Hope, at cancer centers in Europe and Brazil, and then approached actually a panel of experts in kidney cancer and finally a panel of kidney cancer advocates. And what they've done is actually really honed in on a revised survey that takes all the quality of life metrics that we've been subjecting patients to for many years, and I think come up with a short list of 10 or 12 questions that might really be useful in that particular context. While I'm on this slide, I need to give a shout out to my 2 outstanding clinical research coordinators, Danny and Ben, who actually surveyed the majority of patients that were included in this particular study. A lot of legwork in the clinics, and I'm deeply appreciative. So I'm going to wrap up there, and we have actually 8 minutes now for some Q&A. I went through that very quickly just so I could throw some more zingers at my colleagues here. I'm going to take a quick look here and see if there's any audience response questions that have come up. And while I do that, Dave, I'm going to throw a question to you. Okay. This is a tough one.
Okay, I'm ready.
This is a tough one. So, we went through a scenario in our previous Q&A session where a patient who's progressed on frontline therapy and second-line therapy might be receiving belzutifan. Let's picture a gentleman who shows up to your clinic with metastatic renal cell carcinoma. He's been on cabozantinib and nivolumab. He's been on lenvatinib and everolimus in the second-line setting, excuse me. He meets an outside oncologist who starts belzutifan therapy, very appropriate, I think, in that third-line setting. And the patient has anemia. Hemoglobins are drifting down to the level of 7, 8, and he actually is referred by his oncologist to start receiving EPO at that particular time. Patient comes to you and says, well, gosh, I was just, digging through the package insert. It's a very informed patient. And he comes across this recommendation suggesting that we shouldn't be using erythropoietin-stimulating agents. What would you say to that patient in that context?
You would explain that while that's a concern in other groups of patients, it hasn't been seen so far as a problem in the current belzutifan trials. It doesn't mean we won't see it as we start expanding the application of belzutifan to patients with other medical issues who might be at higher risk of clotting for other reasons. For example, patients who are not candidates for clinical trials, we could see it, but up until now, that has not been a problem that has been picked up in any of the case report forms that I've seen. I don't know what others have to say, but that hasn't been an issue. And the good part about Darbo or EPO in that setting is it works really well, quickly, to improve patients' anemia. They often feel much better quickly.
What do you think, Tien? You've gone through the appropriate dose reductions with the patient on belzutifan. Is EPO sort of registering into the equation for you?
Yeah, I think it's a on-target effect, is lower erythropoietin production. So by replacing it, right, it's natural to kind of think about replacing that growth factor so we can allow red cell production. So I would have no qualms to use erythropoietin and talk them through the prior data that was generated with EPO, but not in this particular setting, as David has mentioned very nicely.
Very good. Pedro, I'll throw this question to you. And this is going to sort of build on some of the principles outlined, not in our second line discussion, but in Dave's very eloquent discussion of frontline therapy. You have a patient, and this reflects one of the audience response questions, who has started on frontline nivolumab and ipilimumab, is on for 2 years, has a tremendous response, decides to take a treatment-free interval, at that point in time, and 2 years later is noted to have some metastatic disease reemerge. Let's say at that point in time it's asymptomatic lung metastases. So again, the patient's been exposed to 2 years of nivo-ipi, nivo maintenance, has a 2-year break, then has a really, I would say, minimally symptomatic disease burden, light disease burden. Would you re-challenge with IO at that time?
Yeah, I'm assuming it's not oligoprogression, yes? So
yeah, let's say
you have a few.
Let's say that it's beyond scope of what you can address with surgery or radiation.
Okay, got you. So I probably would, I think the longer you get from stopping or holding the immunotherapy, the more likely are you still to be sensitive to it. So I would not, label that patient as resistant to immunotherapy in that scenario. And so I probably would do that. I was just bringing the other point up because if we have a solitary progression, I probably would address it with local therapy. But in that scenario, Monty, where you're saying there's, let's say a couple of lung nodules growing now, I probably would go back to Nivo.
Dave, what do you think?
I mean, I think it's a great question, not just for that scenario, but that's the scenario we're going to be dealing with increasingly now that Pembro is going to be used so broadly in the adjuvant setting, is what do you do with someone who recurs after Pembro? And the short answer is right now we don't know, and we come up with some of these arbitrary timelines where you might offer it versus when you wouldn't offer it. In melanoma, the trial that got the drug approved for adjuvant melanoma, the Keynote 054 study, patients could get as part of the trial could get Pembro either if they were on placebo or if they progressed off therapy. There actually was a response rate in some of those patients who had a year of Pembro, then recurred subsequently after 6 months. Not as much as it was initially, but there's some activity there. So we need to define what the activity is of PD-1s in patients who've seen a PD-1 therapy. You need to do that, a prospective trial in that setting, so as not to overtreat patients.
Excellent, excellent. I'm going to throw a different scenario altogether to you guys here, which we didn't really address in the context of this talk. Tien, patient presents to your clinic, 68-year-old male with metastatic renal cell carcinoma, lung metastases. Again, let's say this is beyond the scope of what you can apply surgery or radiation to. You're inclined to offer systemic therapy. Pathology in this case, though, is papillary renal cell carcinoma. What treatment might you start with in that setting?
Well, Monty, your PapMet study gives us really great data for cabozantinib in that setting, and the SWOG PapMet-2 trial that Ben Mon is leading, I think would be quite appropriate to think about cabo with atezolizumab versus cabozantinib. So I think the more we can do biologically focused studies, to not just lump non-clear cell disease, but really to separate out those histologies and really ask those pertinent questions, the better we'll actually have data for those patients.
Yeah, makes perfect sense. And we addressed this other non-clear cell study, Pedro, in the course of our discussion tonight, Stellar 304.
Right.
Tell us your thoughts on that. I've heard some rumblings that there's, some critiques of the control arm in that trial with sunitinib. What are your thoughts, or how might you counsel a patient around this?
Yeah, this is a great question. So outside a trial, I tend to offer an IO-based combo, IO-TKI. I don't do IO-IO, but I do tend to offer that based on, a proof of concept, including Cabo-Nivo, LENF-PAM. You show that elegantly. On a trial, I think we really need to establish a new standard of care. You can only do that through a randomized trial, as you highlighted. We're working on the survival, for example, for PapMet, great elegant work that you're working on, and it doesn't seem that there doesn't seem to be a difference. So we actually, to be fair, we've never seen actually survival advantage with an IO-TKI compared to a TKI monotherapy. So I'd argue to Tien's point that TKI is still, and I would argue probably cabozantinib, but and even sunitinib is still the standard of care for those patients. So it's particularly in papillary, I would say. But so I think I think that's if you get access to subsequent therapies. We know that, although David ran a very nicely done work, 427, right, in the non-clear cell cohort, we actually seen activity, but I feel a little bit more uncomfortable offering IO without a TKI component there. So overall, we know there's lower responses for the TKI, but I would argue that if we can do it off trial, I probably would do more. If you do it on trial, that's the way to change standard, and that's what I would advocate for, whether that's PapMet-2, whether that's Stellar 304, or any other trial out there. I think that's the way for us to change practice around the world for those patients.
Great note to end on. I think we do need to do more trials to really resolve standard of care in these rare entities. So with that, I really want to thank you guys. Excellent discussion today. I asked some tough questions, but you got all of them right. So big round of applause for you guys.
That's good.
And I encourage you to complete and submit the post-test and evaluation for this evening. You can download all the slides that we went over tonight, and certainly if you're inclined to, you can watch the replay of this event, which should be available shortly. Thank you to you all for coming out tonight.
Watch the replay.